Hello, good morning, everyone, all participants and other colleagues. So there is a request from Dr. Nina to give her the first because she has some presentation elsewhere. So Nina, please. Age was 2178.
Good morning, all. Can you put my presentation, please? So thank you, AIOS, for this opportunity. So my topic is on strabismus surgery in elderly. Worth the trouble? Results of an objective and subjective analysis. So we know that strabismus in elderly has a significant negative impact on their lifestyle, not just on their well-being and image, self-image appreciation, but on their visual function, leading to severe incapacitation in the daily course, functional parameter performance, outdoor activities, work, and interpersonal relationships. So there is a general misconception that adult strabismus is a cosmetic condition, and if you do surgery, you don't get a stable alignment. And even insurance providers do not consider it as a functional surgery and often refuse insurance claims. So my aim was to see if to analyze the functional and psychosocial impact of strabismus surgery in elderly and to assess if the gains are functional or just cosmetic. So this was a prospective study of all patients above 60 years coming to ROPD with squint or diplopia who opted for strabismus surgery from January 2022 to 23. The objective analysis was done with a complete ophthalmic workup and a strabismus evaluation. Subjective analysis was done with a questionnaire 1 week before and 1 month after surgery. Surgery was standard surgery and success was considered. There was no manifest squint with orthotropia, or there was exophoria less than equal to 16 prisms or esophoria less than equal to 10 prisms. And we did a statistical analysis after comparing the pre-op and post-op scores. So objective analysis is based on 3 parameters: presence or absence of manifest squint, binocular vision for distance using the Wurtzford dot test, and binocular vision for near using the stereopsis with Titmus fly. And maximum score was 8, indicating severe functional disability, and minimum score was 0, indicating no functional disability. Similarly, we did a subjective analysis with a questionnaire. This was a modified questionnaire from AS20 strabismus questionnaire. And we asked the patients basically about how they felt about their eyes and whether surgery was done mainly for cosmetic or functional reasons and whether they had difficulty in their daily activities. And this was repeated post-operatively and asked them about how they felt after surgery. Now coming to the subjective analysis, the scoring was similar and a maximum score of indicated 40 with severe disability and minimum 0. So higher the score, greater the disability. So coming to results, we had total 16 patients, 12 males, 4 females, mainly exotropia. You can see the age was mainly in the 60 to 70 years, closely followed by 70 to 80 years. And most of them had less than 45 prisms. Majority opted for functional reasons rather than for cosmetic purpose, and most of them had unilateral surgery. And if you look at the Wurtzford dot test pre-op, you can see a significant improvement in the post-operative Wurtzford dot test as well as in the stereopsis. So, and you can see the pre-operative objective score fell from the 6.4 it fell to post-operatively 2.25, and subjective score also fell from 14.24 to 4.38, and all these were statistically significant, indicating a great improvement in the functional parameters post-surgery. So how was the study different? We used a modified shorter questionnaire, compared both objective and subjective parameters, and showed that there were significant statistical changes post-surgery, and this surgery is very successful in not just aligning, but significantly improving the quality of life both functionally and psychosocially in elderly patients, and it has significant very low risk of complications. So that is what I want to stress. Strabismus surgery in elderly, it's not just cosmetic, it does improve their functional outcome. In today's world, with the nuclear world, with majority of the elders living on their own, they have to do all their activities like driving and doing all their activities. They must be made independent for all these things. Thank you very much.
Yeah, Nina, it was a nice presentation. Do you know whether the eyes were aligned previously? Because you're saying stereopsis has improved at the age of 70.
No, most of them had squint and double vision. That's why they came to us for surgery. So the inclusion criteria included patients with, you're asking whether it was a previous squint or a late onset squint. So most of the patients in our study were, I would say, a decompensated phoria to tropia patients. They were exotropia patients, so that was the most common type of squint.
So what psychosocial impact, what psychosocial improvement did the patient have pre-op versus post-op?
Yeah, so in the questionnaire, we asked them whether they were able to perform certain activities like, reading, watching TV, reading, working on gadgets. Some of them were employed. In fact, 6 patients were already still employed. They were doing their work. Most of them were staying on their own and they wanted to drive. So driving was a big difficulty for most of them. So post-surgery, they all found they could park earlier where they could not park. They were able to watch TV. They were able to read without closing one eye. And they were able to carry out most of their activities independently. So that was the scoring which we analyzed in the subjective analysis. So I think that was a big change.
One more thing can be included is you can give revital therapy to these patients, and it will help more.
Yeah,
Post-surgery.
revital therapy is usually we do it for amblyopes.
It has many things can be improved with this.
Okay.
You can go to the Revital stall 75 and
No,
get
I
the
have
details.
revital vision at my
Yeah,
center.
Yeah, so it has come out with many things nowadays.
Okay.
So even in cases, this will help.
Okay, thank you.
One small question, like, is your sample size enough to give this conclusion?
Yeah, so that is another thing. So sample size is low, but we are continuing the study. It was just a 1-year study, so we are continuing the study to see if it can be published later.
Okay, thank you.
One thing is not clear in your, like in the inclusion criteria. It is like concomitant or non-concomitant?
Yeah, so in our study we had 16 patients. So all patients were comitant except one patient with thyroid strabismus.
I asked
Comitant strabismus.
in your inclusion criteria,
Ah.
have you mentioned about the
Yes. In my due to lack of time, I didn't include in the slide. Yes. So all patients had comitant strabismus except one patient with thyroid ophthalmopathy who had an incomitant strabismus.
there is a difference?
Yeah. Yes.
Patient is concomitant. After 8 you do it at 180 year, doesn't matter. But after 50 or 60 years, mostly squints are paralytic squints.
No, so-
their management and things are different.
Yeah. I do understand that.
Okay. Can you please call the next one?
You can call.
Shall I call the next one? Yeah.
In the order.
Yeah, so next we call upon Dr. Kuldeep Kumar Srivastava. Yeah. He will be presenting on superior rectus transposition for treatment of isotropic DRS.
And one thing, please try to finish in 4 minutes. The 2 minutes are for discussion and questioning. Okay.
Good morning to all of you. I am going to present my study on superior rectus transposition for treatment of isotropic duodenal retraction syndrome. Author has no financial interest to disclose.
Your mic.
As you know, the DRS is described as moderate to severe limitation of abduction, usually esotropia and primary position, anomalous his posture, and diplopia and attempted abduction. The surgical goal in DRS is to correct head posture, horizontal deviation, globe retraction, upsuit and downshoot, and also to improve the abduction and diplopia-free field. The procedure to improve abduction has been, since long back, it has been the vertical rectus transposition, which is most effective, but it can induce the vertical deviations, and there is a risk of anterior segment ischemia if it is combined with medial rectal recession, making 3-muscle surgery. Then superior rectus transposition described by Johnson in 2006. So purpose of study was to study the efficacy and safety of superior rectus transposition in the treatment of DRS. It was a retrospective study, and isotropic duodenal syndrome underwent superior rectus transposition between July 15 and December 22 were included in the study. Information extracted from the case record were pre-op and post-op head turn, pre-op post-op deviation, pre-op post-op ductions 0 to 5. The surgical technique was as described by the Johnson. It was superior rectus transport adjacent to the lateral rectus along with the spiral of Tillox. Augmentation was done with non-absorbable suture and placed at 8 mm posterior to the muscle insertion. No scleral anchoring was done. There was 12 eyes of 10 patients who underwent this procedure. 7 were male, 5 female. 8 has left eye involvement and 2 has both eyes. All has superior rectus transposition with medial rectus recession. All has augmentation sutures. The mean follow-up was 3 years. And pre-op, post-op, mean esotropia and primary position improved from 21 to 6. Abduction improved from 3.5 to 2.6. And head posture improved from 20 to 5. Abduction improved in 9 eyes, and one patient developed 8 prism hypertropia but resolved spontaneously. This was a girl, 80-year-old girl with left eye DRS1 with ET and face turn. Following surgery, the face turn improved, esotropia improved, and abduction also improved. This was another child, 17-year-old with left eye DRS1 with ET and face turn. Following surgery, ET improved and face turn improved and abduction improved. This was a 13-year-old girl with left eye DRS ET. Following surgery, face turn and esotropia improved, but there was not much improvement in the abduction. The full tendon vertical rectus transposition has been the most effective in improving the abduction deficit and range of BSV, but it has been associated with surgically induced vertical deviations and potential risk of anterior segment ischemia, especially if combined with medial rectus recession. Superior rectum transposition, which was described by Johnson, it has the similar result as the VRT, reduces the amount of surgery and reduces risk of anterior segment ischemia. In our study, abduction improved in 9 eyes, which was similar to the other studies. One patient developed surgically induced hypertropia, which resolved spontaneously. This was probably due to the inadequate dissection of the superior rectus muscle. To conclude, superior rectus transposition is a safe and effective procedure for improving abduction in isotropic DNS syndrome. Thank you very much.
So SRT for DRS ISO is known already. So anything new you are adding?
It just, I did the same procedure which has been described.
Okay.
So the esotropia range from 15 to 30 prism diopters.
Yes, sir.
So, but you have done MR recession with superior rectus transposition with Foster in all patients.
Yeah.
So, don't you think a patient with 15 versus a 30 prism diopters would have different results? I mean, some surgical strategy should be altered rather than doing both the procedures in that patient.
Actually, less than 15, I am avoiding this procedure, and above 15 prism diopter, I am doing this procedure. And so far, I have not got any overcorrection.
Did you have limitation of adduction in some patients? Because one of the photographs was showing.
Yeah, it's we are getting -1 adduction.
Next time any clip, if you add any clip, then this is for good literature for viewers. Some little clip, even 30 seconds, is more meaningful than the, or even photograph than the sketch.
Okay.
Is more meaningful to the scientific deliberations or papers.
Okay.
But otherwise, very good. Very people are doing all these things. So, very nice presentation.
So, can we have the next speaker, please? Professor Raman. No, ये co-author. Sorry, Dr. Nandini. Sorry, co-author.
So good morning to all the panelists and delegates present here. My topic of presentation is challenges, success, failure in surgical management of CFEOM patients. So as we all know, it's a congenital and non-progressive ophthalmoplegia, unilateral or bilateral restrictive strabismus, which will present with or without ptosis. It's mainly due to congenital abnormal innervation of the extraocular muscles, resulting in fibrosis and atrophy. The challenges we are facing while operating CFEOM cases are multiple surgeries are needed and unpredictable outcomes because of the restrictive nature of the condition, and extraocular muscles are shrunken and fibrotic. Inclusions are inclusion criteria is all cases of CFEOM patients attending our tertiary eye care hospital in a period of 6 months who have undergone surgery is included, and family history was taken, and old pictures of the patients were verified. Complete ophthalmological assessment including visual acuity, ocular motility examination, anterior and posterior segment evaluation, forced duction test, neurological assessment of all the cranial nerves were done in all the cases, and ptosis evaluation is done wherever it is needed. And it's a case 1. It's a 4-year-old male patient who presented with bilateral ptosis, which is symmetrical, and presented with a gross chin elevation, Both eye is hypertropic 45 degree, and vertical motility is grossly restricted. There is no elevation beyond midline, and horizontal motility is grade 4 limitation is there in all the cases. Palpable fissure height in primary cases in right eye 3 millimeter and in left eye 4 millimeter. LPS action is poor in both eyes. There is no improvement in ptosis with eye spec test. And in this case, we have done both eye 8 inferior rectus recession, and there is cross improvement in the compensated head posture, and hypertropia is reduced. And there's the second case, a 10-year-old female child. She has a past history of surgery. 5.5 bimedial rectus recession was done. She presented 5 years later with consecutive exotropia, for which we have done, which is of 70 to 75 prism diopter basin. We have done lateral rectus supramaximal recession along with medial rectus advancement, and amniotic membrane graft was done. And this is a case 3, and 17 years old male who has 45 degree exotropia in both eyes and hypertropia 15 degree. In this case, we have done both eye supramaximal lateral rectus recession along with the inferior rectus recession in left eye. In this case, we didn't achieve any good surgical outcome, which shows that CFUM has unpredictable outcome. So, conclusion, our aim is in surgery of CFAOM patient is to improve the quality of life of the patient and not the ocular alignment, since the clinical features of CFAOM are often variable and surgical outcomes are often unpredictable. As we can see in case 3, with no improvement in the compensated head posture as well as the ocular alignment in the primary position. And in case 2, operated prior for esotropia landed up in consecutive exotropia. CFUM type 1 shows good results after surgery due to improvement in head position and an acceptable ocular alignment in primary case after inferior rectus recession as seen in case 1. Other types of CFUOM other than type 1 has unpredictable outcomes. Thank you. Hello.
What precaution do you take while doing inferior rectus recession so that there is no lid retraction post-operatively?
We should not go beyond 7 to 8 recession, and there will be chances of extracorneal fat prolapse and complications will be there. And regarding lid retraction,
So, because the type of the prognosis would depend upon the type of CFEOM, but so how would you, how many patients and what classification did you have in your patient? Because you didn't tell us how many had 1, 2, 3 or 4 type.
yeah, because of the restriction of slides, like 12 slides for this presentation, I have not included. Type 1 is basically both bilateral, it's autosomal dominant.
In your patients, you had a few patients. So how many had type 1, type 2, type 3,
Yeah,
type 1?
first patient, the 4-year-old male child, he belongs to CFUM type 1 because there is no associated neurological abnormalities, both a hypertrophic gross vertical motility.
That's okay. I'm just asking what are type 1. Did you have type 2 also? Type 3, type 4 in your?
Yeah, that exotropia child where we didn't achieve the primary position eye gaze and any compensated head posture improvement, that case is CFUM type 2.
So you should have in your result section, you should have you correlated your results to the type of CFEM.
Okay.
That would have been better.
Aparajita Banerjee.
Good morning, everybody. Today my talk will be on clinical outcome of strabismus surgery in few cases of acute acquired concomitant esotropia. Acute acquired concomitant esotropia is a very rare type of esotropia characterized by sudden onset of concomitant esotropia along with diplopia. Now features that
Can you please speak in a little closer to the mic? Thank you.
common features which I found in all my cases well, medium to large angle concomitant esotropia of acute onset, all were non-accommodative in nature, all were associated with diplopia and presented at age greater than 5 years, and in all my cases there was no tendency for spontaneous resolution even after 1 to 2 months of follow-up. This was a retrospective study carried out at the ophthalmology department of SCB Medical College and Hospital, and the medical records of all the patients diagnosed with AACE were reviewed from the time period January 23 to September 23. Now, inclusion criteria, all the cases of concomitant esotropia with acute onset along with diplopia and with visual acuity, best corrected visual acuity more than 6/9 in each eye were included. Exclusion criteria, non-concomitant esotropia, accommodative concomitant esotropia, amblyopia, patients with past history of ocular surgery and BCVA of less than 6/9 in either eye were excluded. Complete medical history, ophthalmological evaluation, orthotic evaluation were performed on all the patients. Age at onset of onset of squint was verified from the patient's history as well as from the photographs from the patients. The angle of deviation was measured in all the cardinal points along with primary gaze after full refraction by PBCT both for distance and near. Stereopsis was measured and all the cases were sent for neurological consultation, and NCCT, brain and orbit was done for all the cases. In all my cases I could find out there was no history of strabismus and no neurological disorder was found. But surprisingly, we had 5 patients in my series and 4 out of them had increased use of smartphone use and increased digital screen time use in the last 6 months. Now these are my first case scenario of 40 prism diopters esotropia. These are the other cases, case 2 40 prism diopters esotropia, case 3 35 prism diopters esotropia, case 4 50 prism diopters esotropia, and case 5 40 prism diopters esotropia. Age distribution, one patient was less than 15 years of age, others were all more than 15 years of age, and one patient was female, apart from that all were male. Etiological factor, as I already told, 4 cases were found to be associated with increased use of smartphone use, and 1 cases could be associated with increased frequency of driving in the last 6 months. So according to the case wise type of surgery, for case 1 and case 5 we went for bilateral medial rectus recession. All the other 3 cases were selected for unilateral medial rectus recession along with lateral rectus resection, and post-operatively we could see all the patients were orthotropic, and till now the follow-up. So to conclude, I will tell the increased smartphone use will be an important and etiological factor for the acute onset of AACE syndrome or the recent surge in AACE syndrome in nowadays. And strabismus surgery serves as a very useful method to treat large angle acute acquired concomitant esotropia. And in few of the cases which we have operated, we find there was no significant difference between bilateral medial rectus recession and unilateral medial rectus recession along with lateral rectus resection. Thank you.
So all your patients were diplopia free following surgery?
Pardon, ma'am?
All your patients were diplopia free following surgery?
Yes, ma'am. They were diplopia free.
And what was your refraction?
Sir, 2 of my patients were -1 and -1.5 diopter myopic. Rest were.
I'm asking about the retinoscopy of, and what was the mode of refraction for esotropia particularly?
So I had atropinized and then full cycloplegic refraction on all the patients.
Okay.
But no significant refractive error was there, so we didn't prescribe any glasses.
So this association, like you're trying to hypothesize that smartphone or like prolonged near vision
near
focusing
activities, yes.
is induced the esotropia is not connecting well.
In few of the case.
And what was the age, mean age?
One case was less than 15, like she was 12-year-old girl, and rest or from 20 to 25.
Okay.
One was 45, I think. One was a very old patient. One was 45.
No, 35.
No, can you show?
35. One was 35. One she said 35.
Okay.
Anyway, so you said smartphone use is an important risk factor for.
I said, sir, it could be. Means future studies, my case are very limited.
Now, did you try
future
to find any association statistics to derive this conclusion?
Sir, in few of the recent case reports, increased use of near activities and convergence have led to the AAC syndrome, Francis-City syndrome.
But then
iodine.
what I mean is statistically it should be significant
Yes, sir.
to
Yes, sir.
derive this
But
conclusion.
one of my demerit is I have very few
this one.
cases.
So you have done stereopsis examination preoperatively. So what did you find in that?
Sir, it was reduced.
And how many had diplopia?
All the patients had diplopia, sir. That's why they were operated.
So diplopia and stereopsis.
So asking very pertinent questions for this case study. Basically, rather than symptomatic like diplopia, measuring the diplopia, you should have measure all like what is your refraction and what is your accommodative convergence and all. And stereopsis is also a very important part.
Yes, sir.
So that should be, you have only 6, 7, how many cases?
I have only 5 patients.
5 cases, so that can be easily tabulated for the stereopsis,
sir.
all
I'll
that.
keep in
And
mind, sir.
stereopsis is a very important part of.
Yes, sir.
And again, using my smartphone and all this, leaking the CD body spasm or something like that, and also maybe something, unless you're not connecting well.
Jasprit asked one question about stereopsis. So how can a diplopia patient have stereopsis? That is a basic, very basic.
No,
thing.
that they will not have stereopsis.
So you don't. That's what you should have answered.
Yes, yes.
And so if they have diplopia, why do you want to measure the stereopsis?
Yes,
So
sir,
you
exactly.
don't need to do all these things in all these patients. And why did you do bilateral in some and unilateral in?
Sir, those cases in which I have done bilaterally, the esotropia was alternating. It was not fixed to one eye. And in cases which was where the predominantly it was fixed, I opted for unilateral.
Okay, fine.
So next is Dr. Sampada Kulkarni Irlekar. Oh, sorry. Dr. Tisha Vepa Komma.
Yes, thank you. Can I have my slides?
Slides, please.
Thank you. Very good morning, everybody. Okay. Today I will be talking about a retrospective review of consecutive exotropia in a tertiary eye care center. So as we all know, consecutive exotropia is the outward deviation that appears after a primary surgery for esodiviation, and the prevalence has been reported between 4 to 29%. While the exact cause is not known, the presence of amblyopia, early surgery for the esotropia, presence of any dissociated deviations, and poor stereopsis are some of the factors that have been implicated, and the procedures that we choose are an MR advancement or an LR recession or both. So the aim of our study was to retrospectively analyze the clinical and surgical profile of the patients with consecutive exotropia and our outcomes. We included all the patients who presented to us with consecutive exotropia and went ahead with the surgery between January 2014 to December 2021. Any patients with any other ocular conditions, any history of trauma, or any neurological conditions were excluded from our study. So our electronic medical records were retrieved, and various data in terms of the history of the patient, examination, intraoperative findings were collected and analyzed against the deviation at post-op day 1 and 5 weeks post-surgery. So we analyzed a total of 46 patients, in which majority were females. We saw that the age at primary surgery was 3 years, a median of 3 years, and the median duration of presentation was 4 years, but there was significant recall bias associated with this demographic. And majority of the patients, 82% of them, underwent a bilateral MR recession for a diagnosis of infantile esotropia. And in the clinical characteristics of the patients presenting with the XT, the preoperative exotropia was a mean of 34 prism diopters with a very wide range of standard deviation, and majority of the patients underwent a unilateral MR advancement. 50% of our patients were amblyopic, and even though the stereopsis was unavailable for 30% of the patients, you can see that only 0.06% had a good stereopsis of 70 to 100 seconds of arc. We had a slipped MR noted in 2 patients, and the pseudotendon was documented only in 10 of the patients with a median of 4 mm, and mean MR advancement performed was 4.7 mm, and mean LR recession was 6 mm. So when we analyzed the factors such as age at first surgery, spherical equivalent, the duration to presentation, and the primary deviation before the surgery for esotropia, we saw that none of these had a statistically significant influence on the outcome, but I would like to discuss the results a little later. So a mean deviation of 16 prism diopters of exotropia was noted, and while success was achieved in 76% of our patients on the first postoperative day, due to postoperative drift, we had it decreased to 47% at the end of 5 weeks. So while we saw that none of these factors such as age at primary ESO deviation and age at primary surgery and the spherical equivalent did not have a significant outcome influence on the outcome, the presence of amblyopia had a weak correlation, and the presence of amblyopia did not affect the amount of exodrift or the outcome. But 75% of the patients who had a deviation more than 40 prism diopters showed the presence of amblyopia. The presence of pseudotendon had a weak positive correlation with the final outcome. And in our patients, post-operatively, orthotopia was targeted and we achieved a dose response of 4.11 prism diopters per mm, except in the cases of the patient who was operated for partial acquired ET, where the patient did well with reduction of the hyperopic correction, and one in which there was a large pseudotendon in which the resection itself corrected the deviation. And this being a retrospective study, influence of stereopsis and suppression could not be analyzed due to insufficient data. A single surgeon has not evaluated and operated on these patients. There was significant recall bias for the duration of exotropia which they presented. And due to postoperative exodrift, we suggest that an augmentation of standard dose for the LR recession, as well as advancing the MR to the original insertion, especially in the presence of dense amblyopia, may give good postoperative outcomes. And maybe we look at a postoperative target of 5 to 10 prism diopters of esophoria. Thank you.
So, how many patients had DVD in your series?
So, DVD we had about a total of 46 patients. DVD was documented in about 6 to 7 patients.
So, what was the result in these patients? Because that's very important when you're dealing with, when you're having overcorrections.
Because there was only 6 patients, we did not use it to analyze on the outcomes, but they also were in the group of more than 40 prism diopters of deviation.
DVD is a very important part of the esotropia, particularly infantile esotropia. Sir, question is very pertinent in this.
Yes.
So mainly, most of cases, even they are early, when we do surgery early at the age of 3, and they are manifesting after 4 or 5 sometimes. So sometimes they are not manifested before the surgery.
Correct.
So, what literature say about DVD in the infantile esotropia? It's more than 30%.
What does literature say of the presence of DVD in infantile ET?
Yeah.
Yes, definitely we see DVD in the presence of ET, but when these children were operated, whether it was present or not, we don't have sufficient documentation. And when we, yes.
Yeah. Okay, what they were operated in your institute or elsewhere?
Not all. So that's why one of the demerits is that there is significant recall bias related to both the amount of deviation they were operated for and the age as well as the duration for presentation
No
for
records.
exotropia.
No records.
Some had records, but not as detailed as it would have been if they were from our institute.
But
wherever they were operated in our institute, we had those
but it would
available.
be if you design or study like something, then all patients are operated in your institute, so data
is
can
more
be
robust.
analyzed.
Yes,
Yeah.
definitely.
But otherwise, good study, and till now we know by our practical experiences under correction, over corrections, if we do surgery early, only dilemma is that if you do early surgery, then the consecutive exotropia and even manifestation of DVDs in later stage.
Yes, correct.
Yeah.
So we have not found something very significant in our study, but we see that our post-op results are not as great as we are probably thinking they are.
Yeah.
That is all.
Did the amount of MR recession have an effect on consecutive exotropia?
No, in my study, no. But again, because of the patients, not all were operated from our institute, so the data on that was not as specific. Yes. One patient had MR advancement of 4. Okay, so there was one patient in which there was a large pseudotendon documented. So in that, the patient underwent very minimal advancement because the correction of the resection of the pseudotendon itself seemed to have corrected the deviation.
Otherwise, also, what is like now you are what is your capacity?
I'm a fellow in pediatric ophthalmology. Yes.
So you do take count of axial length still?
Axial length, no, but spherical equivalent, yes.
No, no, I'm talking what you measure axial length for before the squint surgery.
No, as part of refraction evaluation, yes, but you're talking about the
On the part of planning,
planning.
even short eyes
So,
students
okay.
more chances of exotropias.
Oh,
So
no.
simple do a scan and then assess eyes, even small eyes going to be more exotropic.
Okay, yes, no, this is not something we look at. Yes.
Otherwise, also, how do you measure your measurement in
When we're operating for esotropia,
during operation for a kid of 3 years?
so less than 1 year, we measure from the limbus, and more than that, we take standard dosage. Yes. Yes.
Thank you.
Thank
Thank
you.
you. Nice presentation. So can we have the next speaker, please, Dr. Pragya?
Good morning, everyone, respected judges. I'm Dr. Pragya Bhattacharjee, and I will be presenting on Helvesen syndrome, its patient-tailored management, a case series. As we all know, Helvesen syndrome or the triad exotropia is a rare intriguing set of strabismic conditions that manifest as dissociated vertical deviation, overaction of superior obliques, and a pattern of exotropia. In this paper, I will be reporting 4 such rare cases of Helvesen syndrome who attended our strabismus OPD, who were surgically operated with a successful post-operative outcome. Now, there could be a variable permutation of surgeries to choose from, but to pick on only one set of surgical procedures become extremely challenging pertaining to the variable extent of the presentation, the unpredictable outcomes of the surgery, and the multi-stage surgical procedures. Like one key does not fit all locks, likewise, the management of Helvesen entails an individual-oriented management. It is a prospective study of 4 patients. They were thoroughly evaluated as per our Squint proforma, and based on the magnitudes of deviation, the surgery of choice was chosen, and post-surgery, they were on regular follow-up. Now, case 1 is a 24-year-old male complaining of outward deviation of both eyes, right eye more than left eye since birth, and on post-occlusion, we found a very significant A-pattern exotropia of approximately 40 prism diopters base in. He also presented with both eye superior oblique overaction, as we can see in the 9 cases, and associated with the DVD, which was associated with extorsion and abduction of the deviated eye with fine latent nystagmus. To manage this case, he underwent a left eye lateral rectus recession with medial rectus resection and its muscle transplantation, and both eye superior oblique posterior retinotomy, as we can see in this video. Post-operatively, a very good correction of DVD was seen, a collapse of the A pattern was seen, and also a correction of the superior oblique overaction was seen. Case 2 is a 20-year-old female who had minor decrease of all the 3 components of Helvesen syndrome, and therefore a singular surgery of the horizontal muscles comprising of an LR recession with its half-width infraplacement and a medial rectus resection was done, following which we saw a very good outcome of the surgery. The third case is of a 20-year-old female who had, along with a 20 prism diopter basin of A pattern, moderate degrees of superior oblique overaction and moderate amounts of DVD, and for which she underwent a lateral rectus recession with its half-width infraplacement and a Faden's operation of the superior rectus. Post-operatively, we have seen reduction in all the 3 components of Helvesen syndrome. The fourth case is of an 18-year-old female who presented with a 15 prism diopters of A pattern of exotropia and who had a very large angle of dissociated vertical deviation, and therefore, first, initially, she went on for a lateral rectus recession with infraplacement and with medial rectus resection with muscle transplantation. And in the future, we will be posting her for a posterior retinotomy of superior oblique both eyes. Post-operatively, we have only seen a collapse of the A pattern. Therefore, in this current study, we report the surgical outcomes of 4 cases of Helvesen syndrome. While there is no particular dictum, but each surgical management was customized to the patient's degree of A pattern, the superior oblique overaction, and the DVD. 3 out of 4 cases underwent multi-stage procedures to achieve the optimum outcome. Cases with larger magnitudes of deviation required combined surgeries. However, it can also be customized to increase the likelihood for a single surgery to provide positive outcomes, as we have seen in case 2. This is a summary of the 4 cases. We have seen that there is reduction in all the components of Helvesen syndrome. However, there remain certain residuals, but I believe that in the light of the cosmetic outcome that the patient has achieved, these remain minimally significant. Therefore, to conclude in this present series, all the cases of Helvesen syndrome following surgical procedures have shown optimum outcome, acceptable to them and tailored to the magnitudes of deviation. With this, I conclude. Thank you very much. Thank you, ma'am.
What was the follow-up of your patients?
So we did a 1 week post-op day 1, 1 week, 3 week, 3 months, and on 6-month follow-up, sir.
And so for the DVD, what did you do? Just the Farden suture, or did you do a superior rectus recession also?
So I didn't understand. For DVD?
For your DVD,
yes, sir.
How did you manage your DVD in these cases?
So if the degree was between 10 to 20, so we went on for a Faden's operation. If it was more and associated with the superior oblique overaction, then PTSO was done, sir.
No, but it's Helvesen, so it would be associated with superior oblique.
Yes, sir.
So
for moderate grades, we went on to do a Faden's operation, but otherwise it was only PTSO, sir.
And what is your capacity as a presenter?
So I'm a postgraduate PG Y2, sir.
Okay, and what is the criteria? How do you decide your anterior transposition of inferior oblique?
So inferior oblique, sir?
The dose, surgical dose.
So we will only do an inferior oblique when there is involvement, but in Helvesen we don't.
No, we are placing all the
anterior transposition of anterior oblique, of inferior oblique is also done.
Where are you placing at the level of inferior rectus, or +1 or +2 or +3 or -1?
So I'm not sure, sir. I don't know.
Just go for it.
Yes,
It's there. Okay. And
sir.
for DVD, even with the patterns. And inferior oblique is very good muscle and give very good results, and by very forgiving muscles. So there's a lot of there. Just go through the literature and you'll find.
Okay, sir. Thank you, sir.
Dr. Pragya, nice presentation.
Thank
Good
you,
that
sir.
you have included a lot of videos and all pre and post-op pictures.
Thank you,
Otherwise,
sir.
nice presentation.
Thank you, sir.
And one thing more, once try to we are presenting the science, so be on scientific, more tables, less words, and more picture. Or if you can include the video of the important procedure, that is more contributing for more
I agree,
science.
sir. Yes, sir. Thank you, sir.
Next, we call upon Dr. Shanmugha. Modified Nishida's procedure.
Can I start, ma'am?
Yes, yes.
Yeah. Good morning to one and all present here. Here my paper being on surgical demonstration of modified Nishida's procedure. Coming to the purpose, here the purpose is to surgically demonstrate modified Nishida's procedure for 6th cranial nerve palsy, monocular elevation defect, and 3rd cranial nerve palsy. It's not moving ahead.
Slides, please.
Slides are not moving. Please help.
Yeah.
Yeah.
Coming to the materials and methods, study design. In this study, we are presenting case series of 6th cranial nerve palsy, 3rd cranial nerve palsy, and monocular elevation defect who underwent modified Nishida's procedure. The study area was done at the Minto Ophthalmic Hospital, Regional Institute of Ophthalmology at Bangalore. Coming to the methodologies, we selected 3 patients after preoperative squint evaluation, having first patient having both eye more than 45-degree esotropia due to 6th cranial nerve palsy post-trauma. Second patient, right eye 15-degree hypertropia with mild exotropia since birth. Third patient, left eye 15-degree exotropia due to 3rd cranial nerve palsy since birth were included in the study. Inclusion criteria, basically the patient who had informed consent for this procedure, and exclusion criteria being no previous history of squint surgery. Coming to the preoperative evaluation, The case 1, sensory test, Bagolini's left eye suppression, Rutherford is suggestive of left eye suppression, visual acuity, right eye 612, left eye 624. Motor test, Herzberg's birth eye more than 45-degree esotropia, PBCT for the distance 50 PD for base out in front of both eye, and PBCT near 50 prism diopter base out in front of both eye. Coming to case 2, Bagolini's right eye suppression, Rutherford is right eye suppression, visual acuity was 6.9. Motor test, Herzberg, 15-degree hypertropia with mild exotropia, neutralizing with 30 prism diopter in both up and down gaze, and for near 30 prism diopter in both up gaze and down gaze. Coming to case 3rd, that is according to Bagolini's, there was left eye suppression and Rutherford left eye suppression. Visual acuity was 612. Motor test, Herzberg, 15-degree exotropia. PBCT for distance is 30 prism diopter basin in front of left eye, and PBCT near 30 prism diopters basin in front of left eye. So as you all know, it's a little tough to understand the squint surgery. So we have wanted to do an innovative by doing a surgical model demonstration for Nishita's procedure. As you can see here, first we take an bite on the muzzle, which is around 8 to 10 mm in order to prevent the breakage of the muzzle during the transposition, and then around 10 to 12 mm measurement is taken from the limbus and the muzzle. In case if there is a requirement for the horizontal muzzle weakness, we take with the vertical transposition, and vertical muzzle we take the horizontal transposition, and we can see that we are anchoring the muzzle to the sclera distance from 10 to 12 mm from the limbus. This is a small surgical demonstration with of the patients where horizontal muzzle resection, transposition is done. And here we are going ahead with the vertical. So when there is a vertical muzzle, we go ahead with the horizontal muzzle transposition. When there is horizontal muzzle weakness, we go ahead with the vertical. Coming to the post-operative, case 1 where there was bilateral 6 cranial nerve palsy. Post-op right eye was almost orthotropic, and post-op left eye also was almost orthotropic. Case 2, monocular elevation defect. Here also you can see the patients are orthotropic with a slight exotropia, which was not explained. Coming to case 3 with the 3rd cranial nerve palsy, the patient had almost orthotropic. So coming to the discussion of result, case 1 presented with both eye more than 45-degree exotropia. Patient initially underwent medial rectus recession of 10 mm in both eye as initial correction, followed by which patient underwent modified Nishita's procedure for both eye. Preoperative neutralization was with 50 prism diopter for both distance and near. And then case 2 was with patient presented with 15-degree hypertropia. Post-op there was mild exotropia, so patient underwent ptosis correction along with modified Nishita's procedure. Case 3 post-op was orthotropic. Coming to discussion, modified Nishita's procedure involves the suturing of the muzzle to the sclera, and therefore the transposed muzzle can generate required force at the sutured point. In modified Nishita's procedure, the step of muzzle splitting is omitted to prevent damage and to preserve the anatomy of the extraocular muscles during the surgical manipulation. So as you know, this procedure, this procedure has few scleral passes, reduce muscle damage, thereby preventing anterior segment ischemia and the preservation of the anterior ciliary vessels. Thank you.
Depending on the amount of deviation, did you do the titration?
So actually first one was like more than 45-degree exotropia, as I already mentioned. In modified Nishita's procedure, there were certain articles like where there was only correction with only 30 to 35 prism diopter correction was there. So first case, which was a large angle deviation, we first initially underwent medial rectus recession, followed by which we took up for the modified Nishita's procedure. And other two cases, because the prism deviator deviation was not very large, so we directly we enrolled the patient for the procedure.
What was the duration of the deviation?
So first one is post-trauma, which is around 6 months. The second child where there is monocular elevation defect since birth, and third also it was since birth, sir. That is third cranial nerve palsy.
And what does duration of large duration, then what precaution will you take? What test pre-operative would you do before starting your surgery?
I didn't understand.
Before starting surgeries, usually we do some test.
So basically we wanted to see how much neutralization was with prism was there to...
No, on the table. On the table. Simple test, usually we don't talk about that test. पकड़ के कुछ करते हैं देखते
Force
हैं?
reduction, I mean,
हाँ,
force reduction test, FDT.
and okay, so that is quite helpful
To
before starting.
okay, sir.
And when you do the conjunctival recession, when you plan conjunctival recession in addition to all these tests,
Conjunctival recession.
have you heard of this?
No, I'm not sure of that.
Huh?
I'm not sure of that.
You are doing advanced transplantation and you are not sure about this? Okay, go.
Okay.
It's very important.
Okay.
So actually, what is missing is you should have shown the pre-op photographs in the cardinal position in the diagnostic positions of gaze,
Okay,
because then
sir.
we would know what is the ocular motility, what is the limitation,
Okay, sir.
and what is the important thing you have to see when you're doing a Nishida. That is very important thing. The surgical aspect, like who was the surgeon? Did you ask him or? Because you have large angle strabismus here. So what happens? Nishida says maybe 30 to 40 prism
30 to
diopters.
35 prism
Yeah,
diopter correction.
so what you have very large angle strabismus here. So would that have corrected it?
So yes, sir, that's why that only
Medial
I told.
rectus recession you've done.
My first case had very large angle deviation more than 45 degrees. So we first the patient posted for medial rectus recession, followed by which he was taken for the modified Nishida's
Yeah,
procedure.
but there is one very important step when you're doing this Nishida procedure. What is that? That's
Ah.
how you will get your effect.
So anchoring to the sclera, distance of anchoring
No,
to the
so basically the intermuscular septum on the opposite side has to be cleared. That is how the pull will come.
Okay, sir.
Otherwise, it'll keep on. It'll be tightened, and maybe you have a recurrence of some degrees later on.
Yeah, okay.
Your capacity as a presenter, your PG,
Third year.
procedures were done you.
Yeah, no, it was done with my chief author was there, and I assisted the cases. Thank you, sir.
Actually, we are
Thank you, sir.
running out of time. I think, yeah. Next, we call upon Dr. Ankita Man.
Good morning everyone. I am Dr. Ankita Man from KGMEO, Lucknow. My topic is limbus insertion distance of horizontal recti on anterior segment optical coherence tomography and axial length on A scan and its correlation with comitant horizontal strabismus, a pilot study. What is known, there is a good correlation of limbus insertion distance on ASOCT with the surgical measurements. But what is unclear, correlation of limbus insertion distance with type or severity of deviation or surgical effect of recession or resection. All previous studies have used intraoperative measurement to determine this correlation. Intraoperative measurements are not in physiological state and have limited accuracy. Hypothesis, limbus insertion distance of horizontal recti measured on SDAS-OCT correlate with the type of deviation in comitant horizontal strabismus. Aim is to measure limbus insertion distance on spectral domain anterior segment OCT and axial length on A scan in patient with comitant tropias and to compare limbus insertion distance and limbus insertion distance to axial length ratio with age-matched controls. Objective are to correlate in patients of esotropia, exotropia and age-matched control the limbus insertion distance for medial rectus and lateral rectus and limbus insertion to axial length ratio. Study setting at Department of Ophthalmology, KGMU, after ethical approval. Study duration 3 months. Study design cross-sectional analytical study. Inclusion criteria are patients giving written informed consent, cooperative for ASOCT examination, age more than 6 years. Exclusion criteria is refractive error more than 5 diopter, previous ocular surgery, sensory and vertical strabismus. ASOCT scan was done using ASOCT, Cirrus SDOCT with an anterior segment attachments. Measurements for medial rectus and lateral rectus done. Measure of readings from 3 scans recorded. Muscle insertion to the anterior chamber angle measured using software caliper provided by the device. Axial length measurement will be done with a scan. Sample size, no previous study has been conducted to correlate the measurement on ASOCT with ocular deviation. This was a pilot study and all consecutive samples over a period of 3 months. A total of 29 esotropia, 10 exotropia and 13 control sample were analyzed. statistical analysis, mean plus minus standard deviation and range of limbus insertion distance was calculated for exotropia, exotropia and controls and compared using unpaired t-test. Limbus insertion distance to axial length ratio was correlate in case and control using unpaired t-test. A p-value of less than 0.05 was considered statistically significant. Results in which mean limbus insertion distance to axial length ratio for medial rectus and lateral rectus found statistically significant. There is no significant, statistically significant difference was found between the mean of limbus insertion distance of horizontal recti in comitant strabismus. However, a statistically significant difference was found in the limbus insertion distance to axial length ratio in case compared to controls. Conclusion, limbus insertion distance to axial length ratio in comitant horizontal strabismus is significantly different from age-matched control. It correlates with the type of strabismus. Thank you.
Just one question. How accurate are you when you do the measurements with the AIOC? Were they correlated intraoperatively? Did you do any surgery on them? Any patients were operated? Any patients with ESO or exotropia were operated? Because AIOC it's a little variable when it gives your results. It's not that accurate. So they have to be correlated with your intraop findings before you actually have a study saying that this is the correlation with the axial length.
Yes, sir.
Again, it's not OCT. Basically, the give roughly idea. Otherwise, when you do the squint surgery, this surgeon's own experience of some time. When what type, when at what level you are cutting and what level you are suturing. So this is surgeon associated with many factors. Okay. So
Next one. Dr. Nitish, thank you. Dr. Nitisha Khare. We have only 11 minutes. वही ना और दो बच्चे
I'll be presenting on comparison between conventional recession and handback recession of extraocular muscles for squint surgeries. So strabismus, as you know, is malalignment of eyeballs in which both of the eyes are not directed simultaneously at the objective regard. It needs to be corrected because it leads to disturbances in binocular single vision and would lead to diplopia, confusion, eventually leading to suppression and even amblyopia. It may even cause cosmetic concerns to the patient. So the common treatment modalities available include optical treatment in the form of refractive error correction or prisms, ortho-optics and surgery. Surgery is the mainstay of treatment, and surgical procedures are broadly divided into strengthening procedures and weakening procedures. My study today aims at comparing two types of weakening procedures, that is conventional recession and hangback recession. So the basic principle behind both the surgeries are the same, that we are basically disinserting the muscle from its original site of insertion and we are reinserting it certain mm behind. So the difference, what this does is that it reduces the tension on both the muscles and it would reduce the arc of contact, thereby reducing the strength of the muscle. In conventional recession, we suture the muscle back a certain mm behind over the sclera, and in hangback recession, instead of suturing it, we let the muscle hang using the suture. So my study aims at comparing the two types of surgeries, and it was conducted at MNJ Western Regional Institute of Ophthalm, Civil Hospital, Ahmedabad, between August 2020 to July 2022, and we had a sample size of 60. We included 60 patients with concomitant strabismus. The patient's age group was more than 5 years, and only patients with primary surgery were included. The patient's consent was taken, and pre-op evaluation was done. And using prism bar cover test, the prism diopter's deviation was calculated, and accordingly the extent of recession and resection was planned. On follow-up, the patients were evaluated, and the study and the results were evaluated. So amongst the 60 patients, 24 were females, 36 were males, and age ranged from 8 to 40 years, mean age being 23.78 years. 4 of my patients had esotropia, and 56 had exotropia. 14 were unilateral deviations, and 46 had alternate deviations. The mean pre-op deviation for near in conventional group was 54.5 plus minus 15 prism diopters, and for distance was 57 plus minus 15.01 prism diopters. In the hangback group, pre-op deviation mean for near was 47 plus minus 4.82 prism diopters, and for distance was 50.46 plus minus 5.419 prism diopters. The mean post-op deviation on day 90 was compared between the two groups, and no statistically significant difference was found. The successful outcome, we considered it to be less than 8 prism diopter post-op. It was compared, and again no significant difference was found. The post-op eye movements, on post-op day 1, 29 out of 30 patients in both the groups had some degree of restriction of movements, while by day 60, 25 out of the conventional recession group and 27 in the hangback recession had regained complete movements. Again, no significant difference was found. So, what do we realize? We find that the post-op correction, movement restrictions, there was no any difference found. Complications also, no major complications were noted in either of the groups in my study. But as we study the literature, we find that as the hangback recession avoids the scleral pass, as a result of which the risk of scleral perforation, which is a major complication during the surgeries, is avoided. So especially in patients with thin scleras like high myopes, it is a very good surgery to be considered. And when we need longer recessions, in conventional recession, it is difficult to suture the muscle back over that behind the sclera. So in those cases also, hangback recession can be a very good alternative to consider.
Okay, this is well established that there is not much difference between these two techniques, but what is the novelty in your study?
So we compare the study, if any.
No. Take it, then it's okay. Yeah.
For PG, one question. Scleral perfusion can be happen at the attachment at muscle site also.
Yes, sir, that can happen.
Yeah.
But so usually the, yes, so that is a risk.
So what is one disadvantage of doing your hangback?
So it has been found in some cases that in later stages pseudotendon formation may occur, which may lead to late
so that is the main reason. Even if you have to do large recession, you do hemi hangback.
Yes,
so you try to prevent this complication.
So even adjustable suture hangback can be.
Yeah.
But that means not in the long
very
run.
good thing.
Yeah.
One more disadvantage is you keeps titrating time and again.
And one thing more, there are the two schools of the Americans like more hangback and British like more conventional surgery. So there are two schools like this.
Okay, since we are running short of time, next, thank you.
Thank you, sir.
Yeah, thank you. Dr. Reena Gupta.
Good morning, everyone. So my talk is on the motor outcomes of free muscle surgery for large angle strabismus. Large angle strabismus has been defined by most of the investigators as an angle of deviation which ranges from 40 to 90 prism diopters. At present, there is no common consensus on how many muscles to operate. But the aim of the surgical management is to achieve a satisfactory motor alignment in the primary position without inducing lateral concomitants. So we did a pilot study at PGIMS Rohtak. With the purpose of the study was to evaluate the alignment, the motility, the binocularity, and the cosmetic outcomes of free muscle surgery. The medical records of the patients who had committant esotropia or exotropia and angle of deviation was more than 50 prism diopters, and they underwent 3 muscle surgery in the last 1 year. They were retrospectively reviewed, and patients who had minimum of 6 months follow-up, they were included, whereas cases with amblyopia, paralytic or restrictive squint were excluded. The motor alignment and sensory examination was done with patients wearing the optical corrections, and the ocular deviation was measured pre and post-operatively by prism bar cover test for near and distance in all cardinal positions of gaze, and the lateral concomitance was measured in prism diopters by noting the difference in angle of deviation in the lateral gazes. And the surgical procedure which we did was bilateral LR resection with MR resection for exotropia and vice versa for esotropia. Important thing was the dosage. We divided the amount of surgery to be done depending upon the angle of deviation in the 3 muscles with the same dose of recession which was done for same muscle in each eye. The follow-ups were noted at 6 weeks and 6 months. We defined the successful surgical outcome as binocularity restoration, orthotropia or deviation within present diopters, no limitation of ocular motility as well as cosmetic correction. Undercorrection was defined as residual deviation which was more than 10 prism diopters, and overcorrection as consecutive more than 10 prism diopters. So we had total 16 patients, 4 patients at esotropia and 12 patients at exotropia. Age of presentation was from 5 to 33 years. Myopia was seen in 27.78% of the patients and hypermetropia in 16.67% of the patients. We had very successful motor outcomes of the 50% at 6 months of final follow-up, and consecutive deviation was seen in 6.25% of the patients, whereas residual deviation was seen in 43.75% of the patients with the range from 10 to 35 prism diopters. There was no limitation of ocular motility. The dose response effect which we obtained was the accumulated response was around 3.80 prism diopters per millimeter for esotropia and 3.70 for exotropia. So in most of the studies on 3 muscle surgery, they have claimed very successful outcomes of 70 to 80%. We obtained only 50%. The reason was that the group of patients which was included had constant exotropia more in our study as compared to other studies where they've included intermittent exotropia patients as well. And that gives the reason for not much improvement in the binocularity in our patients, whereas the alignment was quite stable even after 6 months. And similar to other studies, abduction deficits were seen in minority of the patients. That also improved over time. Very successful cosmetic corrections up to 75% of the patients, hence with no significant lid fissure changes. And the dose response which we get was 20% less than what we get in 2 muscle surgery usually. It's a retrospective study. It has a small sample size, short follow-up, and no comparative study. So I conclude that simultaneous surgery in 3 muscles is a very effective way of treating large angle strabismus with successful outcomes and not inducing any lateral incompetence and good cosmetics satisfaction on the part of the patient. Thank you.
Dr. Reena, nice presentation. However, if you had pre and post operation pictures, if you had added, that would have given more credibility. Secondly, as you have stated, sample size is too low to give this statement because others have done a very large number of studies.
Yes, I think it's a pilot study which we started 1 year back. So patients actually with getting a patients over 50 prism diopters when you include and concomitant strabismus. So we could come across 16 patients only, and the agenda was follow-up also, because when we included follow-up 6 months, the number of the patients went down.
So what is the cutoff amount of deviation where you go on to 3 muscle surgery?
Yes, now for if we talk about exotropia, so the recession I usually don't do above 9.5 millimeter for LR, because what I have seen that over and moreover the resection which we add.
No, my
so
question is pre-op deviation. At what?
Okay. Yeah, up to 50 prism diopters. So if I get 55 prism diopters or 60, I go for 3 muscles now.
Below 50, you do 2
yes,
muscles.
2 muscles below 50, and above 50, usually above around 60 prism diopters, we go for 3 muscles.
Do you advise anything to the patient for the abduction deficit he gets?
Actually, what I have seen over time that after 2 muscle surgery, the abduction deficits are much more as compared to 3 muscle surgery. Because in 3 muscle surgery, you have 3 muscles, so usually we can limit our recessions or resections. Yeah. So usually abduction deficits we didn't.
No, why 3 muscles? Why not 4?
That's a good question. Actually, 4 muscles. So what I feel is that when you have one spare muscle in hand, it's sometimes strabismus is very
No, I went. This is a pointed answer for this.
Consecutive can occur.
No. The simplicity is that you divide all in 4 surgical doses, 4 muscles. Symmetry is there. If you are doing asymmetric surgery in both eyes, then your lid aperture will be difficult. So at the end of the day, this is the cosmetic surgery also.
Yeah.
So in case of one muscle doing that, even try to do symmetrical surgeries.
Yeah.
Yes,
But
that is the reason resection and resection people are not doing. They are doing either both symmetrical. Okay, so that is the reason. Okay.
Thank you so much.
The surgeon's choice what he or she likes.
Okay, so thank you everyone. Yeah. Thank you everyone. Please say. Thank you so much everyone for all the participants and other colleagues sitting here and be the part of the session. Thank you so much.
We have one moment. You can have photograph for all the speakers.
Yes. Photography. You one, yeah. Sorry.